Here I am again. I'm like a pop-up on your screen, aren't I? Well, I'm Menopause Taylor, your gynecologic educator, and I teach you absolutely everything. This is Menopause Taylor University. So here we are at video number 471. Today we'll be talking about pre-menopausal polyps that can pop up in your reproductive organs. Seems that there are pop-ups everywhere these days. There are shops that pop up. There are website warnings that pop up. And today we'll discuss polyps that can pop up. And by the end of this video, you will be an expert. This is yet another video bonus that you will not find in my book. And since our focus today is on pre-menopause rather than post-menopause, pre-menopausal polyps are not a pop-up in my book. So, have you ever heard the word polyp? If so, do you know what constitutes a polyp? Last week, I taught you all about uterine fibroids. Do you know the difference between a fibroid and a polyp? How about a quiz question on this? I just love quiz questions. The difference between a fibroid and a polyp is A. Fibroids grow only in the uterus, whereas polyps grow only in the cervix. B. Polyps grow only in the uterus, whereas fibroids grow only in the cervix. C. Fibroids are hard and solid, whereas polyps are soft and fleshy. D. Polyps are hard and solid, whereas fibroids are soft and fleshy. E. It is uncommon to have multiple fibroids, but very common to have multiple polyps. F. It is uncommon to have multiple polyps, but very common to have multiple fibroids. G. Fibroids grow in both the uterus and the cervix, whereas polyps grow only in the uterus. H. Polyps grow in both the uterus and the cervix, whereas fibroids grow only in the uterus. I. Fibroids can cause bleeding, but polyps can not. J. Polyps can cause bleeding, but fibroids can not. Don't you hate it when I give you answer options that are so similar? Well, I do so because it requires you to really think about the options. I just gave you two versions of each answer. Only one of each can be correct. So without ado, I'll pop the answer on the screen. All right. Let's define polyps first. The general definition of a polyp is a protrusion of tissue that juts out or pops up from a surface that outlines the cavity of an anatomical structure. Now, anytime you have a surface that outlines an anatomical structure, it's because the anatomical structure forms a cavity or open space of some kind. So the key words for defining a polyp are protrusion, surface, and cavity. So a polyp is something that juts out or pops up from a surface that is supposed to be flat. And it's supposed to be a flat surface so that there is an open cavity with nothing in it. You have all sorts of body parts that are supposed to be flat surfaces lining open cavities. I mean, the entire inside of your long gastrointestinal tract, the inside of your bladder, the inside of your uterus, and the inside of your cervix, which is the bagel hole that functions as a door. I mean, I could go on and on. Well, a polyp constitutes an overgrowth of the flat surface such that it protrudes into the cavity. And it looks kind of like a mushroom. So here I have a flat surface. And the flat surface is part of some kind of cavity. It can be a cavity of any shape. So let's use this to represent the actual cavity. Now this area in here is supposed to be empty. It's a cavity. But a polyp protrudes from the flat surface into the cavity like this. Now, you may say, so what? What difference does it make if there's a mushroom popping out into the cavity? And the answer depends on the function of the tissue on the surface of the cavity. So it depends on what this surface is. And since there are all sorts of flat tissue surfaces forming cavities in your body, the significance of a polyp depends on the particular cavity. For purposes of our discussion today, we care about polyps in two locations: your cervix and your uterus. So let's address them separately, and we're going to start with uterine polyps. So, I have taught you that the tissue lining the inside of your uterine cavity is kind of like grass. So this represents the surface on the inside of your uterus. Okay? And it responds to estrogen and progesterone. Estrogen makes the grass grow, so it's like fertilizer. Progesterone makes the grass shed, so it's like a lawn mower. Well, if you have a uterine polyp, it's like having a mushroom growing out of the grass. So it would be kind of like this, but unlike this mushroom that looks like something completely separate from the grass, a uterine polyp is really just more of the endometrial tissue that lines the inside of your uterine cavity. So a uterine polyp is really a massive protruding overgrowth of grass. So what you really have is this. The grass is there, but the grass is also on the mushroom. And what is going to happen to this protruding overgrowth of grass in response to estrogen? Well, estrogen will fertilize the grass so much that there's way too much grass. Both the flat surface and the polyp will grow in response to the fertilizer. It will constitute an example of hyperplasia, or too many layers of cells, like I taught you in the unit on cancer in general. And what's going to happen to this protruding overgrowth of grass in response to progesterone? Progesterone will mow the overgrown grass, which will constitute a very, very heavy period for you. So, most uterine polyps cause heavy bleeding. Fortunately, they cause heavy bleeding when they are still quite small. So this enables early diagnosis and treatment. Bleeding is usually the only symptom that hints at a uterine polyp. They don't cause pain. So while popping up sounds painful, uterine polyps are not. So you usually don't even know a uterine polyp is present until it makes its presence known with bleeding. Fortunately, most uterine polyps are benign. Now, There is also, though, the possibility that this protruding overgrowth of grass can represent a collection of cells that is transforming into cancerous cells. Your doctor can usually diagnose a uterine polyp by seeing it on an ultrasound. They are not as easy to see on ultrasound as uterine fibroids, and that's simply because, as indicated by the quiz answer, fibroids are hard and solid, whereas polyps are soft and fleshy. So if you have bleeding that is heavy or unusual, your doctor will probably do a pelvic ultrasound as the first step to a diagnosis. Here's a photo of a single uterine polyp on pelvic ultrasound. The darkest black area is supposed to be an empty cavity that extends to the upper left quadrant of the photo. But instead, there's a light gray oval-shaped structure jutting out into the cavity. That's the uterine polyp. And here's a photo of multiple uterine polyps on pelvic ultrasound. Once again, the darkest black cavity in the center is supposed to be completely black and empty. But the three light gray structures are three separate uterine polyps. But an ultrasound is usually not enough for diagnosis of a uterine polyp. A pelvic ultrasound can only describe how a polyp looks. It cannot tell you anything about the cells in the protruding overgrowth of grass. Remember, most uterine polyps are going to develop as a result of the lining in your uterus being too thick in the first place. In the unit on cancer in general, you learn that hyperplasia is when there are too many cells or too many cell layers. Then, in the unit on uterine cancer, you learn that most uterine cancers begin with hyperplasia. Endometrial uterine hyperplasia is when the endometrial cells lining the inside of your uterus become too numerous. So endometrial uterine hyperplasia is when the grass has become overgrown, usually due to too much fertilizing and not enough lawn mowing. And the polyp is an outgrowth of the lining that is already too thick in the first place. So the next step to diagnosis is to get a sample of the tissue from your inner uterine lining. And there are several ways to do this, some much better than others for making the diagnosis. The goal with sampling of your endometrial cells is to collect a sample that reflects what's going on in your uterus to cause the bleeding. And this is the most important part of the evaluation for providing a diagnosis. The process of sampling involves collecting endometrial cells from the lining inside your uterus and sending them to the pathology lab for examination under the microscope. That way, you determine on a microscopic cellular level what's going on. In the unit on uterine cancer, I divided the different ways of performing endometrial sampling into two different categories based on visibility and totality. Visibility refers to the types of endometrial sampling that are done blindly. In other words, your doctor collects the sample but cannot see the inside of your uterine cavity while doing so. He or she inserts some type of device and collects cells from your endometrial cavity without being able to see what your endometrium looks like and without being able to see where in your uterus the sample is taken. Well, think about this. A uterine polyp is an outgrowth in a specific location in an open cavity which constitutes your uterus. What if the sample fails to include the polyp? What if the sample takes tissue from this location and this location, but not this location. If that happened, you'd miss the diagnosis. Other endometrial sampling techniques are performed under direct visualization. They enable your doctor to actually see inside your uterus while collecting the sample. And that means he or she can see what your endometrium looks like and where they are taking the sample. If there's a uterine polyp visible anywhere, your doctor can make sure he or she samples the uterine polyp. The second factor is what I've called totality. By this, I mean that some devices collect a sample of endometrial cells from your entire endometrial surface, whereas others only collect random samples from a portion of your endometrial surface. Obviously, the more complete the sampling, the more accurate the diagnosis. If a biopsy device samples a normal area of your endometrial lining but misses the polyp, your diagnosis could be incorrect or missed altogether. Some gynecologic abnormalities affect the entire endometrial cavity, but a uterine polyp does not. So how the sampling is done can affect your ability to get an accurate diagnosis. So there are 3 different techniques for sampling your endometrial lining. They are dilatation and curettage, endometrial biopsy, and hysteroscopy. I will discuss each of them. The first technique for sampling your endometrial lining is a dilatation and curettage. You probably know this as D and C. D is for dilatation, C is for curettage. The word "and" separates them. It is D and C, not D in C. Remember, your cervix is nothing but a door to the uterus. And the door is just a hole, like the hole in a bagel. And all this door does is open and close to let things go in and out of your uterus. But the vagal hole constitutes a very tiny door that is usually closed. So your doctor has to dilate your cervix or open the door a bit in order to sample the cells in your uterus. So dilatation involves inserting probes that gradually increase the size of the door to your uterus and make the vagal hole large enough to insert the necessary instruments. These dilatation devices are kind of a lot like the varying sizes of makeup brushes. Once your cervix is dilated, the next step is to insert a device that can collect a sample of your endometrial lining. For a D&C, that device is a curette. Here is a curette. You can see that it has a deep rim. So it's like a tiny spoon with a big hole in the middle of it. Your doctor inserts this device and uses it to scrape the interior of your uterine cavity and collect endometrial cells. The medical term for scraping is curettage. D&C was the traditional method for endometrial sampling until about 1975. But there are shortcomings to D&C as a means of collecting endometrial cells. The first shortcoming is that it requires general anesthesia. Dilating and scraping are too painful to do them without it. And the second shortcoming is that a D&C is done blindly. Your doctor cannot see where he or she is scraping or if they are sampling the entire endometrial cavity. As much as 50% of your endometrium may go unsampled. In the 1970s, the D&C was replaced by an in-office sampling device called an endometrial biopsy device. As the name implies, it's a device for sampling the endometrial tissue, and it can be done in the office without anesthesia. The biopsy is called an endometrial biopsy, or EMB, and that's because it's a biopsy of your endometrial tissue inside your uterus. The most common device used for doing an endometrial biopsy is a tiny little suction device. So here is a typical drinking straw. And here's an endometrial biopsy device. As you can see, it's very, very tiny. It's a tiny little catheter. Well, because this catheter is so tiny, there's no need to dilate your cervix. It's usually possible to slide this right through your cervical door and into your uterus. And this is true even if your cervix is quite closed. Now, occasionally it's not possible, but most of the time it is. So, your doctor merely inserts this through the opening in your cervix and up into your endometrial cavity, and then pulls back on the piston to cause suction. But compared to the size of your entire endometrial cavity here, this little suction device is teeny tiny. And this is used blindly also. So if you have a uterine polyp, this device is likely to miss it. On average, this samples only about 4% of your endometrial cavity. So compared to a DNC, these EMB devices represent a trade-off of convenience for an inferior specimen. Because of the blind nature of both DNC and EMB, as well as their inability to sample the entire endometrial cavity, a negative result does not rule out a uterine polyp. If the results of your DNC or EMB are negative, you usually have to proceed to the next step, which is also the next option for endometrial sampling: hysteroscopy. Hyst means uterus, and scope refers to an instrument that enables you to see something. So a hysteroscope is a device that enables your doctor to look inside your uterus. And the word hysteroscopy is the process of looking inside your uterus. It's kind of like attaching a camera to this EMB device so that you can see what you're sampling. And that increases the reliability and accuracy of the biopsy. So that way, I can still do it in the office setting without anesthesia. Obviously, I still would not be sampling the entire endometrial cavity, but by seeing the cavity, I could choose the sites that look most abnormal, and I can sample the polyp specifically. Or if I use a larger scope to do the sampling and can see what I'm doing through the scope, I'll get an even more thorough sample. I can even remove the entire uterine polyp. And there are some larger devices that apply complete suction to the entire cavity and remove all your endometrial tissue so that all of it goes to the pathology lab for microscopic examination. Of course, all these gadgets cost money, and the more sophisticated the gadget, the fewer the number of physicians who have it or know how to operate it. And then there's the matter of cost. The more sophisticated, the higher the cost of performing the biopsy. And if insurance is involved, there may be a limit on what they'll pay. But in any case, the goal is to obtain tissue in order to label the bleeding with an accurate diagnosis and either rule out or confirm the presence of a uterine polyp. All tissue collected by any of these means goes to the pathology department for evaluation under the microscope. Now, sometimes the pathologist returns a diagnosis of tissue insufficient for diagnosis or quantity not sufficient for diagnosis. They both mean that there is still no diagnosis. Either there just isn't enough tissue to make the diagnosis, or the tissue is so confusing that the pathologist can't give it a name. The ideal scenario is to identify and remove the actual uterine polyp. Polypectomy is the name of the procedure that involves removing the entire polyp. And it's really very simple, but it requires seeing the actual uterine polyp. To perform a polypectomy, your doctor simply grasps the base of the polyp with forceps and just twists the polyp off of its base. And there you have it. Now, this may be merely diagnostic, or it can be both diagnostic and therapeutic. It's diagnostic only if it does not completely remove the polyp or if there is additional pathology. It's therapeutic if it does completely remove the polyp and there is no additional pathology. So if the pathology report designates the polyp as benign, then a polypectomy may be all you need. But if the pathology report designates the polyp as malignant, you'll need additional surgery for treatment. And fortunately, the majority of uterine polyps are benign. I guess the most important thing to know about premenopausal uterine polyps is that they tend to recur. So if you've had one uterine polyp, there's a good chance that you'll have more in the future. Just don't put uterine polyps in the category of one and done. They fall into the category of first of many. So polyps can pop up again and again, and each one is new and requires a full evaluation. So, as you'll see in the upcoming videos on perimenopause, uterine polyps can pose as one of the perils of perimenopause as well as premenopause. All right, now it's time to shift gears from your uterus to your cervix. Everything I told you about the general nature of a polyp is still true, regardless of whether the polyp is in your uterus or your cervix. The polyp is still an outgrowth of tissue that protrudes into an open space that forms a cavity. The difference is location. A uterine polyp originates up here, and a cervical polyp originates down here. Notice that I used the word originates. I did so because we define the polyp as uterine or cervical by where it originated. It's always about the kind of cells that popped up and jutted out into the cavity. You see, it is possible for a uterine polyp to protrude into your cervix. So if that happens, it's kind of like this. And if it does, your doctor can see it on vaginal exam. But that alone does not make it a cervical polyp. It is a uterine polyp that has protruded into your cervix such that your doctor can see it by looking into your vagina. Here's what your doctor would see. Here you can see the normal cervix in the light pink color. But that dark, beefy red tissue jutting into the door of the cervix originates in the uterus. So this is a uterine polyp that is protruding through the cervical door. But a true cervical polyp originates in your cervix. So a cervical polyp is an outgrowth of your inner cervical lining. A cervical polyp originates here, down here. So this is a uterine polyp. And this is a cervical polyp. The distinction is that the tissue lining the inside of your cervix and uterus consist of two different types of tissue. You see this line? In the Uterine and Cervical cancer, I taught you that your cervix has two sides. It has a uterine side up here, and it has a vaginal side down here. And this line separates the two sides. The uterine side of your cervix is lined with the same kind of cells as the inside of your uterus. So if a polyp originates on the uterine side above this line, it constitutes the same kind of cells as those on the inside of your uterus. Those cells are soft, cushy, and fragile glandular cells like this, and the polyp will behave as a uterine polyp. But the vaginal side of your cervix down here is lined with skin cells that are exposed to your vagina. So if a polyp originates below this line, it consists of skin cells that are different than those on the inside of your uterus. Those cells are flat, thin, and tough skin cells like this, and the polyp will behave as a cervical polyp. So a cervical polyp looks like this, and the key is to realize that a cervical polyp originates from the part of your cervix that is exposed to your vagina. So the appearance of a cervical polyp originating from your cervix is a bit different. It looks like this. Notice that instead of being beefy and red in color, this polyp is light pink. Well, light pink is the same color as a normal cervix. So now you know why I have both a red balloon and a pink balloon popping up here and there. A cervical polyp is not as fleshy and fragile as a uterine polyp. That's because it does not consist of glandular cells. It consists of skin cells. So it's smooth, like skin. So what's the difference in the behavior of a cervical polyp compared to that of a uterine polyp? Well, it all has to do with the cells that constitute the polyp. You already know that uterine polyps bleed spontaneously, but you know, there's not much activity going on in your uterus other than the thickening and shedding of the inner lining on a monthly basis. But there's a whole bunch of activity going on in your vagina. The most active thing of all is sex. If you have sexual intercourse with a penis or a sex toy, it's going to bump the exposed cervical polyp. So a cervical polyp gets bumped with just about any kind of sexual device that you insert into your vagina. The cells composing a cervical polyp are tough. They can withstand a whole lot more abuse than the fragile cells lining the inside of your uterus. So instead of bleeding spontaneously, these tough skin cells only bleed in response to trauma. And bumping is what causes a cervical polyp to bleed. So the most common symptom of a cervical polyp is what we call postcoital bleeding. Postcoital bleeding is bleeding after intercourse. So how do you diagnose a cervical polyp? Well, if you go to your doctor for postcoital bleeding, he or she is going to do a pelvic exam. This is your pelvis, and here's the vagina. And the first step in a pelvic exam involves looking into your vagina. Of course, your cervix sits at the top of your vagina, and your doctor can see a cervical polyp very easily on pelvic exam. And all he or she has to do for treatment is a polypectomy. So, he just grasps the base of the polyp with forceps, twists the polyp off its base, and voila, it's gone. That gives you the polyp to send off for tissue analysis. And if it's benign, then the treatment is done. The polypectomy constituted the treatment. If it's malignant, then you'll need additional surgery for treatment. Fortunately, most cervical polyps are benign. So now you understand the differences between uterine polyps and cervical polyps. So your summary for today is as follows. A uterine polyp is a mushroom-like protrusion of the endometrial tissue inside your uterus. The typical symptom of a uterine polyp is heavy bleeding. Diagnosis is via pelvic ultrasound and tissue sampling of the polyp. If the tissue sample is benign, a polypectomy serves as both diagnosis and treatment. If the tissue sample is malignant, a polypectomy serves as a diagnosis only. A cervical polyp is a mushroom-like protrusion of the cervical tissue that is exposed to your vagina. The typical symptom of a cervical polyp is postcoital bleeding. Polypectomy can serve as diagnosis and treatment of a cervical polyp. Okay, we have just one more topic to tackle in the pre-menopause section, and that is the timing of your transition into perimenopause. So you can plan your timing to watch that video in a week. You know that you can schedule a consultation with me at menopausetailor.me for polyps or just about anything at any time. I do them with women of all ages, and it doesn't matter where you live because I do them all online. Another good way to plan your time is to subscribe to my channel and newsletter right now. Following me on social media is something you can do in your spare time. And that's about all the time we have today. Bye, my dears.